Hello, good morning and good afternoon, everyone. Thank you very much for making time to join our post-ASCO webinar from Tempus. We have an excellent program organized today with three faculty that will join us. We will give a few minutes just to allow some people to continue to join over the next minute or so. While we wait, if you would please note that you may ask questions using the Q&A button on the Zoom application, and feel free to write your questions in. We will attempt to answer as many questions as we can, and we'll probably do most of that towards the end of the program. Let's give a few minutes to a minute or so just to allow more people to join. I see there's about 30 right now. Okay, we're at 2 minutes after, so I think we should go ahead and get started. I think we'll continue to see some participants joining us in the next few minutes. Welcome, everyone, and thank you again for joining. This is Tempus post-ASCO webinar titled The Evolving Landscape in Precision Oncology, Key Research Findings from the 2023 ASCO Annual Meeting. My name is Dr. Calvin Chow, and I'd like to introduce our panelists for today. First, we have Dr. Ramaswamy Govindan, Professor of Medicine from Washington University in St. Louis at the Siteman Cancer Center. We also have Dr. Catherine Handy Marshall, Assistant Professor of Oncology, GU-Oncology Specialist at Johns Hopkins Medicine. We also have Dr. Ezra Cohen, who has recently joined Tempus as our new Chief Medical Officer, and we're thrilled to have him on board here at Tempus. He's been here since ASCO, actually, and previously from University of California, San Diego, where he specialized as a head and neck cancer specialist. And my name again, Calvin Chow, Senior Vice President of Medical Affairs at Tempus. So we're going to start here reviewing the agenda first. We'll actually feature some important data that was presented at ASCO from Tempus. This was actually 2 oral abstracts that cover the topic of germline alterations and the benefits of a tumor normal matched next generation sequencing approach, and talk about the influence of the germline findings on somatic findings, as well as understanding the implications of some of that for certain individuals. Next, we'll also talk about some findings from the Adora trial. There was quite a bit of interesting data in early stages of non-small cell lung cancer management, specifically with respect to testing and adjuvant and or neoadjuvant therapies, and so we'll touch upon that. Thirdly, we'll talk about the latest breast cancer findings from the PADA-1 trial that speak to some of the importances of kinetics of circulating tumor DNA findings, liquid biopsy findings, and I think that would be a nice point to illustrate some of the potential expectations and applications of those tools in oncology practices. And then we'll end up with some discussion in general about the future of precision oncology. Just to start off, I think that most of you know that Tempus does take a unique approach to its sequencing. Physicians have the option of using a tumor normal matched sequencing approach. And what that really means is that one can have the option of submitting a blood sample specimen in addition to a solid tissue tumor sample when performing the XT sequencing test. Effectively, what this does is it allows us to glean exactly which mutational findings are coming from the tumor itself, the somatic mutations, and differentiate that from mutations that are of germline origins. A lot of times when one does the tumor-only sequencing, as represented by the middle panel there, we're going to find variants that are actually emerging from both the somatic tumor itself and the germline alterations as well. And in order to differentiate one from the other, one needs to actually perform both tests so that effectively one can subtract out the blood germline contributions and then yielding a more accurate call on the somatic variants. And this, I think, has really allowed Tempus to provide a more accurate read on its somatic tumor calls, as well as to calculate measurements such as the tumor mutational burden, which we can assure that that the mutational burden is coming from the somatic alterations and not from the germline. And so we'll talk a little bit about this because, in fact, it is this capability that has resulted in investigators coming to Tempus to ask to do research with the data that we've accumulated through our database. And the first two studies that we'll talk about are examples of research that has been done based on this capability. So I'm going to ask Dr. Govindan to please start us off by talking about the first study in lung cancer. Dr. Govindan?
Thank you. Thank you, Dr. Chow. It's great to be part of this program. I appreciate your invitation. I just want to begin by stressing some basic facts. When we look at the tumor mutation landscape, having the germline assessment of the DNA really helps us identify the true pathogenic thing, as Dr. Chow outlined a few minutes ago. In addition, it also allows the germline sequencing, that is, allows us to ask a few questions. And what is the prevalence of pathogenic or likely pathogenic alterations in these patients? In fact, to what extent does this cancer, a product of a germline or underlying susceptibility, genetic susceptibility to get cancer? And the second, I think with time, I think this is where these data will become invaluable, is that are there genetic determinants, germline alterations that predispose patients to toxicities, for example? And I think we'll be able to ask and mine those questions. So we began asking this question several years ago using the Cancer Genome Atlas project, where we had sequenced over 10,000 tumor samples from 33 different tumor types and asked a very simple question. How often do patients with cancer enrolled in the Cancer Genome Atlas project have underlying germline alterations across various cancer types? The answer was 8%, and majority of those alterations involved tumor suppressors. And that was, in my opinion, a landmark paper that really defined these germline alterations. Please keep in mind that the last 10 years, we have learned a lot about the tumor genomic alterations, but very little work has been done on germline alterations. So that data set from TCGA had about roughly 1,000 patients with lung cancer. So we asked this question in this particular abstract that we presented at the ASCO meeting. What about the prevalence of germline alterations in a larger data set, 10 times larger than what we had in the TCGA? So we looked at 10,000 tumor normal samples from the Tempus data set and came up with nearly the same conclusion we had drawn earlier on from the larger data set of all cancers, but a smaller data set from lung cancer patients. That's about 1,000. So in this Tempus data set, we found that 5% of patients with lung cancer had pathogenic or likely pathogenic alterations. And then we drilled down further and asked this important question, are there differences between EGFR mutated lung cancer patients versus EGFR wild type? That's what you see here. And the EGFR mutation in gray and EGFR wild type in blue. And one thing that stood out was germline EGFR mutations are present almost exclusively in EGFR mutant patients, that is EGFR mutated lung cancer patient. And this has been observed in smaller data sets in the past where germline EGFR T790M mutation was identified in some families that put them at high risk for EGFR mutated lung cancer. In addition, we did see changes in DNA repair pathway, mostly BRCA2, ATM, and MUT2IH, and other gene alterations. We also found an interesting fact that small cell lung cancer patients had very few pathogenic germline alterations. So as we learn more and more about these pathogenic germline alterations, we're going to find more and more stuff. But I want to highlight one important fact here. We have been looking at under the lamppost here, looking for the keys under the lamppost, where we looked at about 40 odd genes that have been identified as pathogenic or likely pathogenic alterations, and that's what we focused on. As we know more and more about cancer susceptibility, interaction between the tumor and the germline and the environmental factors, we probably will identify more genes that probably play a role in the pathogenesis of cancer in these patients. These data would come very handy. The take-home message here is 5% of patients with lung cancer have potentially pathogenic or pathogenic alterations. EGFR mutant germline alterations are present exclusively in EGFR mutant lung cancer patients. The most common alterations in patients, germline alterations in lung cancer patients, DNA repair alterations. So those are the three key take-home points.
Thank you so much, Dr. Govindan. I'm actually going to ask Dr. Marshall to present her data, and then we'll have some discussion about both of these abstracts that were presentations at ASCO. So Dr. Marshall, would you like to proceed?
Yeah, thank you so much, Calvin, for having me today. So for us, we know that both germline genomic alterations and somatic genomic alterations can influence not only prognosis, but also therapeutic considerations across multiple cancers. But what hasn't been sort of well established is the interaction between these, so the germline alterations and somatic tumor landscape. And that's why we partnered with Tempus to help us answer this question. So we chose 4 of the BRCA-associated cancers to focus on: breast, ovarian, pancreatic cancer, and prostate cancer. And we were interested mostly in how the germline gene mutations in the homologous recombination repair gene pathway, the HRR pathway, influence the somatic genomic landscape of tumors arising in these individuals. The germline gene alterations that we were interested in were BRCA1, BRCA2, PALB2, ATM, and CHEK2. And we were comparing patients who had those alterations to those who didn't have any of those germline genetic alterations, and looking at 50 of the most common somatic gene mutations that we see in these cancers. So this first graph, I'll walk you through it, is with breast cancer. So this represents 7,008 patients who had been diagnosed with breast cancer. The x-axis down here has the somatic alteration of interest. The y-axis has the proportion of patients. And then each color bar is one of the germline alterations. So this black bar here is showing that and all the way to the left in breast cancer is showing that the TP53 mutation is prevalent in about 40% of patients with breast cancer who have sporadic breast cancer, so no pathogenic alterations in the germline. And when you compare that to what the rates of TP53 mutations are amongst those who have germline alterations, you see that those with germline BRCA1 alterations in blue have a much higher percentage of patients with TP53 somatic mutations, over 80%. And then down here in the blue and green bars, that's, the purple and green, that's germline ATM in purple, and then germline CHEK2 in green. They have much lower frequencies of TP53 mutations compared to those with sporadic breast cancers. The second group for breast cancer is the PIK3CA somatic alteration. And again, the sporadic group has about a 30% prevalence of PIK3CA alterations, and that is actually a lot higher than what you see in germline BRCA1 and germline BRCA2 patients, where the proportions are much lower. And in comparison, for the PIK3CA mutations, those with germline ATM mutations and germline CHEK2 mutations have much higher prevalences, around 40%, compared to those with the sporadic cases. Next, we looked at ESR1, and here the biggest difference is between the sporadic cases, which is, again, is a little bit less than 10%, compared to the germline BRCA1, which has very few alterations. And germline ATM and germline CHEK2, patients with those germline alterations have much higher rates of mutations in the ESR1 gene. Next, we have the FGFR1 gene, and the sporadic cases are, again, about 10%, which is a lot higher than those with germline BRCA1, germline BRCA2, and germline PALB2 mutations. And compare that to germline ATM, which is a lot higher than those with sporadic cases. And then finally, for amongst the breast cancer patients, we looked at ERB2 or the HER2 gene, and the only significant finding here was that those with germline BRCA1 alterations had a lower proportion of patients with these mutations compared to sporadic. The others were not statistically significant. So next, in the upper right portion of the slide, we have ovarian cancer analysis. So this is with 4,310 patients with ovarian cancer. The first mutation that we looked at for ovarian cancer was TP53. And here, similarly to what we saw in breast cancer, those with germline BRCA1 mutations had a much higher proportion of patients with somatic TP53 mutation compared to those with no germline alterations, and those with germline BRCA2 mutations also had a higher rate of TP53 mutation compared to those without any germline alterations. Whereas those with germline ATM and germline CHEK2 had much lower proportions of TP53 alterations. The next section, we have the PIK3CA, where we see that patients with germline BRCA1 and 2 alterations had a much lower proportion of PIK3CA somatic alterations compared to sporadic. And those with germline ATM mutations had a much higher percentage of PIK3CA alterations compared to patients who had sporadic ovarian cancers. Third, we have the KRAS mutations, and similarly to the PIK3CA, those with germline BRCA1 and 2 alterations are lower than those with sporadic alterations, and then there was no statistical difference with the other germline mutations. And then finally, in the ovarian cancer population, the major difference that we saw is with the ESR1 gene, that those with germline ATM mutations had much higher proportions compared to those with sporadic. Next, we looked in the bottom right, the patients with pancreatic cancer. So this is representative of 5,426 patients with pancreatic cancer. Looking at TP53, KRAS, CDKN2A, and then ESR1. So first, looking at TP53, we see that the BRCA1 patients, which is that blue bar, have a higher percentage of TP53 alterations. And then those with germline PALB2 and ATM mutations have much lower rates of TP53 mutations. For KRAS, we see that patients with germline BRCA1, 2, and germline ATM have higher rates, whereas the other germline alterations were not statistically different than the sporadic cases. We did not see any differences by germline alterations for the CDKN2A mutations. And then in ESR1, we saw higher proportions in those with germline PALB2 and germline CHEK2 mutations for those with pancreatic cancer. So then we can go to the next slide, which has the prostate cancer data. So this is representative of 4,526 patients with prostate cancer. And here the somatic mutations that we were looking at were TP53, AR androgen receptor, FOXA1, Tempus ERG fusion, and then BRAF. TP53, some of these look larger, did not reach statistical significance, with germline BRCA1 in blue being a bit higher than sporadic, and then germline ATM being lower than sporadic, although did not reach significance. There were no differences in the AR rates of AR mutations. And then FOXA1, we saw an increase in those with germline BRCA2 alterations. And we saw much lower rates of Tempus fusion amongst those with germline BRCA1 and 2 mutations compared to those with sporadic prostate cancer cases. And then finally, with BRAF mutations, which are not very common overall in prostate cancer, we saw much higher rates in those with germline CHEK2 mutations compared to those with sporadic prostate cancers. So overall, across all of the diseases, there was about a 4 to 6% rate of germline alterations that were found. And again, these are just focusing on the homologous recombination repair genes that we were interested for these 4 cancers. And we did see differences in the somatic tumor landscape across these germline alterations, again, which varied somewhat by the tumor type.
Right. Thank you, Dr. Marshall. So let's talk now about both of these studies and talk in general about what knowledge, or why does the knowledge of germline alterations in general in relation to somatic alterations matter? And Dr. Govindan, if you could maybe first address that in the context of lung cancer. Maybe you could talk about the fact that lung cancer, I think the clinical guidelines today don't necessarily recommend germline testing for patients, but why do germline mutations matter in lung cancer?
Yeah, sure. I think it's a great question. So, number one, I think one way of looking at that is that lung cancer is predominantly a preventable disease. 85% of the times caused by tobacco smoking. And the intrinsic pathogenic germline alterations that lead to cancer are not, very high. So that's a reassuring thing, that patients with inherited germline susceptibility factors are not the one accounting for a bulk of our lung cancer patients at the moment, as far as we know. As I said, in the future, we may find some susceptibilities that are present in the germline that may give them patients at high risk for lung cancer upon exposure to tobacco or environmental exposures or heavy metals. And we'll figure this all out over time. I'm very hopeful about that, at least in some. So at the moment, I think getting a germline sequencing, I always think is a good idea so that you can improve the variant detection in the somatic tumors. So people like us who have been involved in genomic research from day one, have always got the normal tissue DNA sequencing to compare with the tumor tissue to get better at the variant calling, especially for those rare variants that we are increasingly identifying. So I personally think that's always a good idea. Second is, over time, we're going to get some spectacular amount of information, millions of these data over the next 5-10 years with detailed clinical annotation from major cancer centers. And that would enable us to identify, as I said earlier on, are there interactions between tobacco smoking and these germline alterations, environmental exposure on the etiology side. On the toxicity side, we'll be able to figure out, are there alterations that are really putting people at a high risk for chemotherapy-related toxicities? Are there special HLA types that put people at a high risk for immunotherapy-related toxicity? So I think there are many things we're going to learn over time. So I think this information is very critical in my view.
So it sounds like we're still at the beginning of that learning curve about understanding this. In terms of when clinicians sequence, Dr. Govindan, I mean, they find some incidental pathogenic or likely pathogenic germline alterations. What implications are there? What sort of actions could one take there to act on or to not act on those particular findings?
Yeah, I think the important thing is, this is important even before we send blood sample for genome testing. Getting a good family history is quite important. And second is, if you suddenly find somebody has a BRCA mutation, germline mutation, when you get the Tempus report, it's very important to sit with the patients, clarify the family history, make sure that you got all the information right, arrange for genetic counseling, and the relevant family members have to be screened appropriately. I think we need to get help from the genetic counselors, and in order to ferret this information, add additional testing when required. And I think that's an important piece of that information that may have implications for the patient's family members, siblings, as well as the children. So I think that's an important piece of information we periodically identify. And I do think there are times when you will find more and more that the germline alterations sculpt the somatic landscape. We did report earlier on in the TCGA that somatic ATM mutations are associated with lack of P53 alterations in the tumor cells, are infrequent in association, tumor P53 alterations. So we'll find those things. And obviously the BRCA2 germline mutations or BRCA1 would make you think of PARP inhibitor-based clinical trials. So there are some clinical implications as well in the immediate future for the patients.
Thank you so much. Ezra, let me turn to you and ask you, obviously, you've used Tempus at UCSD prior to you coming to Tempus, and, in terms of using this information from the germline, incidental germline findings, I mean, do you have any comments about your use of this information?
Well, sure. I think I would certainly reiterate what we've heard so far in terms of the importance of these findings, not only in the patient in front of you, but a broader understanding of the biology. So certainly the finding, and not rare finding, of a germline level alteration, I think necessitates further counseling and of course, when appropriate, informing especially first-degree relatives. So this is a finding that that would have not only implications, again, for the patient that you're treating, but a broader the broader family group. What I think these data also begin to reveal to us is that there's biologic mechanisms at play here that we are really just beginning to understand. Why are these associations present with such a large data set? One begins to feel that they are real. These are not just spurious findings or chance findings. So why is it that a germline variant associates more frequently with certain somatic alterations and not with others? I think Govind said it really well. We're really just beginning to collect the data and do further studies to begin to understand that. So this is a field that's clearly biologically in its infancy.
Yeah, thanks, Ezra. Dr. Marshall, let me ask you to comment on your findings. What implications did you take away from the collective findings of the study, and maybe you can even comment on what implications might there be for additional researchers or drug development professionals, given what we found.
Yeah, so I think, in prostate cancer, and obviously this varies a little bit by the cancer type, but the indications or the guideline recommendations for germline testing are actually broader than somatic tumor testing. So really should be done in more patients rather than fewer patients than who are getting the somatic tumor testing. But as we think about more targeted treatment, and as more targeted treatment comes out and we see a heterogeneity of responses, we're still trying to figure out why a lot of that is. And we brought up PARP inhibitors before, and we see this in prostate cancer too. If and some of it may have to do with tumor heterogeneity rather, or how tumor testing goes, or tumor mutations change over time, and whether or not they're germline alterations that continue to be present that are drivers or not. And I think that understanding sort of more of the entire tumor and the tumor microenvironment. I see a question in the chat too about clonal hematopoiesis and CHIP, and we had studied that, and And I think all of these things are contributing to sort of the heterogeneity in tumor responses to treatments. And by understanding more of the interactions between like the germline and somatic landscape, we'll better understand that and prognosis as well.
Terrific. Well, thank you. I think there's, we probably spent quite a bit of time dissecting all the individual associations that were found. I don't know if all of these have previously been described, but I need to move on. And so let's go on to the next topic here. So Dr. Govindan, this is yours to present. If you wouldn't mind, please walking us through the findings from the Adora trial and maybe contextualizing the early non-small cell lung cancer landscape in general in terms of testing and adjuvant therapies now.
Thank you. So as you know, EGFR mutations account for about 10 to 15% of all lung cancer, genomic alterations in the setting of adenocarcinoma. And we have shown in advanced non-small cell lung cancer patients that EGFR mutate in the EGFR mutant population, that EGFR TKIs are better than chemotherapy and in terms of progression-free survival. And we have repeatedly shown that with various EGFR TKI inhibitors, osimertinib is now the commonly used frontline agent in metastatic EGFR mutant lung cancer. And fast forward to the era of adjuvant therapies, EGFR mutant patients were treated just like any other patients in the past with standard platinum-based adjuvant therapy after complete resection of non-small cell lung cancer stage 2 to 3, typically. We typically don't give chemotherapy to patients with node-negative disease. In general, there are exceptions to that. But unfortunately, even with adjuvant therapies, nearly 50% of our patients with stage 2 and 3 non-small cell lung cancer did relapse stage 3, a little bit more than that, than stage 2. And it's always been a frustrating problem for both clinicians and a very disappointing one for the patients when they relapse after doing all the appropriate therapy, surgery, and postoperative chemotherapy. So we are clearly finding ways to bend that, improve that curve. And one of the ways we can do that is to target using targeted therapies. And EGFR inhibitors have been tested in many settings in early stage non-small cell lung cancers. Phase 2 trials have shown the feasibility of giving EGFR TKI inhibitors like erlotinib. We began a trial with erlotinib in the National Cancer Institute in the USA many years ago, asking a question whether adjuvant erlotinib would improve the survival. And that study is still ongoing. Enrollment has been completed, but the follow-up in terms of overall survival is still not mature. So we don't have the results for this. In the meantime, osimertinib study has been completed now, done through a global network. Patients with EGFR mutated non-small cell lung cancer, as a part of the Adora trial, received osimertinib in the adjuvant setting, mostly following platinum-based chemotherapy. And these patients, mostly stage 2 and 3A, and some at stage 1B. Earlier presentations focused on disease-free survival, and now the overall survival data were presented because, after all, in the adjuvant setting, overall survival did matter. As you can see here, the hazard ratio was pretty impressive with 0.49 and quite significant. The 5-year overall survival rate projected varied more than 12% compared between osimertinib and placebo, favoring osimertinib, as you can see here. And the most compelling and the dramatic example was decrease in brain metastasis in these patients. So these data, this particular graph is the ultimate endorsement for the use of osimertinib in EGFR mutant non-small cell lung cancer patients following complete resection, stage 1B to 3A. In the US, most of us give after platinum-based therapies. In some Asian countries are using, I'm told, EGFR TKI inhibitors over chemotherapy. But the best data we have are this following platinum-based therapy in this setting. So that's what I would favor, following complete resection, platinum-based therapy, 4 cycles, and then osimertinib treatment. And that's basically, I think, has changed the landscape in this space. An important study.
Thank you, Dr. Govindan. in terms of obviously utilizing this data, one needs to test for EGFR. And could you comment on when to test, what to test for today, and maybe speculate a little bit about how this space will evolve over the next couple of years?
I mean, today in the early stage non-small cell lung cancer patients, after complete resection, two tests are important: EGFR mutation testing, and the second one is, of course, the PD-L1. And that also opens up possibilities for immunotherapy. But if somebody has PD-L1 100% and EGFR mutation in the tumor cells, like exon 19 deletion or L858R, I would favor EGFR mutation-based therapy, that is osimertinib. I would not combine osimertinib with checkpoint blockade. That results in prohibitive pneumonitis rates, and I would not combine them. I would not give checkpoint blockade like pembrolizumab or tislelizumab in lieu of osimertinib. So EGFR mutation patients should get osimertinib in the adjuvant setting. As far as the testing is concerned, currently those are the two pieces of information you should know. You can order them right after surgical resection, and even sometimes the initial biopsy, these tests are ordered. But I do see a future, not in the far too distant future, where I think we would consider customized therapies for other targeted agents if these trials turn out to be equally positive. The ALK inhibitor trial is currently ongoing as a part of the Alchemist programs. I would strongly encourage you to consider participating in the trial. There's accruing patients. And so when you start doing for this gene by gene, at some point it may be more beneficial to order the panel testing. But at the moment, we need these two tests for sure in practice, EGFR and PD-L1.
Great. Ezra, let me ask you if you have any comment here, practical matters about testing, when to test, and what to test with.
Yeah, no, I think Govind covered it perfectly. I was going to ask, or at least maybe provocatively think about alterations beyond EGFR. I think what this trial really does, beyond the obvious role of osimertinib in earlier stage non-small cell lung cancer, but how much will this paradigm extend to other alterations? You mentioned the ongoing trial with ALK fusions, but one would think that the same would apply to ROS1, to BRAF, certainly to NTRK, although those patients get rarer and rarer, or let's say less common, and those randomized studies may be difficult to perform. But this paradigm of a driver mutation in earlier stage disease, and then being able to influence the rate of progression-free survival by targeting that in those patients that likely have minimal residual disease post-resection, I think is one that we'll begin to see over and over again.
Great, thank you. Maybe one last point before we leave this topic. The immunotherapy landscape has also produced a lot of data, both at this ASCO and at AACR, and these are in the both neoadjuvant setting and adjuvant settings. Dr. Govind, could you just comment briefly about that, and when should the neoadjuvant treatment opportunity be taken? I know that's a controversial subject, but if you could just make a brief comment about that.
Yeah, absolutely. Very briefly, and I agree with Estra's earlier point about these various other targeted alterations. And unfortunately, we don't know how to do these studies, right? Getting the EGFR mutant patients was hard enough for us in the adjuvant setting. ALK is proving to be tough, and it's taking time. Much harder for ROS1 and RED. Should we be doing some kind of a novel testing and having intermediate endpoints? And those are interesting scientific questions we cannot cover today. But I do foresee a future where I think we will be taking a very different approach to these, asking these questions. As far as your question, Calvin, that this requires a seminar of its own. And I think immunotherapy, especially in the preoperative setting, has caught many of our attention. And I would say in my practice, I restrict preoperative immunotherapy to predominantly stage 3 patients, if we consider them acceptable surgical candidates. In stage 1 to 2 patients, we typically resect and consider postoperative therapy. And there are a lot of discussions currently ongoing nationally to do this neoadjuvant versus adjuvant therapy. Such trials have not been done. and only they can answer those questions definitively. But this is an emerging area, very hot topic. We can do a lot of correlative studies done in the neoadjuvant setting, but certainly a space to watch in the coming years.
That's great. Thank you very much. Okay, so we're going to move on. This was our discussion slide, so I'll move that on. We'll just touch briefly on this breast cancer update that was also presented at ASCO, the PATA-1 trial from Francois Bedard, who actually presented this original data back a couple of years ago at San Antonio Breast Cancer Meeting. They actually took a look at patients who are being monitored and then subsequently randomized based upon ctDNA analyses done serially at every 2-month time points. The patients were in the first line treated with an AI plus a CDK4/6 inhibitor, palbociclib, and patients were monitored for the emergence of ESR1 mutations. Upon finding those mutations increase, patients were then randomized into step 2 of the trial, which allowed one arm to switch over to fulvestrant plus palbociclib, and then the other arm stayed on the AI plus palbociclib and continued until progression. What this actually update showed was some additional progression-free survival outcomes at the second progression time point, because patients were allowed upon first progression to then for the AI plus palbo arm to switch over, cross over to the fulvestrant plus palbo treatment. And in short, the patients actually fared better with this management schema, where upon detecting these ESR1 mutations in the blood, this is before evidence of radiographic progression, the subsequent treatment with fulvestrant plus palbo did improve overall progression-free survival. And this was true for the PFS1 and the PFS2 outcomes. As well, I think there were some interesting findings about the ctDNA kinetics, where at the 2-month time point, there was the elimination of ctDNA, or the clearance of ctDNA was also prognostic of outcomes for both arms. Ezra, I thought I might have you comment on this, because this is something that perhaps has been also demonstrated in other areas, other disease states, but just, what do we learn here about ctDNA kinetics and the potential application to other cancers in general?
Thanks, Calvin. I think this is really, it's paradigm shifting, because what we're now really beginning to realize is that we can use a test on a longitudinal basis to not only look at treatment response, but for management, and perhaps more importantly, really see when resistance mechanisms begin to emerge, so that we can address them prior to really even anatomic changes in the disease. And one would think, and certainly the data that we're seeing in this in the Kaplan-Meier curves would support that if we do that, then we can get better disease control, or at least longer disease control, than if we don't follow these the changes in these alterations. It has been demonstrated in a non-randomized manner in non-small cell lung cancer, with the emergence of EGFR resistance mutations and the early implementation of next generation EGFR inhibitors. Now, of course, that landscape has changed, as we alluded to earlier in this webinar, that osimertinib, or the next generation, third generation agents are now considered first line. So now, as the paradigms for non-small cell lung cancer treatment have changed, that thinking has evolved. But here's another example really of tracking the emergence of resistance mechanisms, intervening prior to overt progression on radiographs, and extending progression-free survival. And again, if we think about paradigms, this can apply to many other tumors, not only breast cancer, but multiple solid tumors. And I think we'll begin to see many more of these studies in the near term.
Thanks so much, Ezra. So I'm going to shift on over to so this final discussion here, because we really touched upon quite a few topics in this short time. We talked about the importance of germline testing and interpreting germline and somatic findings in conjunction with each other. We've also talked about the landscape that's evolving in early stage lung cancer management, and also I think in the landscape of liquid biopsy usage in at least in metastatic breast cancer management for tumor response monitoring. So let me just ask all of you, and we can kind of take this a rather free-flowing way. How do you see really NGS testing with both tissue and liquid biopsy testing, as well as germline testing? What sort of insights do you have looking forward, and anticipations would you have in terms of how these tools will be impacting how cancer is managed? Maybe I'll start with you, Dr. Govindan.
Sure. I think the good news is we are already here. We are now doing panel testing in a variety of tumors, and it's no longer a question of should you do it. The question is, how often should you do it? It's changed quite a bit. And second important thing is that we no longer stop with testing once. And when patients progress on targeted therapies, now we have a better understanding of the resistance mechanism. We have a number of clinical trials for those patients who progress. And so I think we are beginning to get into this time where, as the drugs are, the drug therapies advance, we have more and more reasons to test these tumors over and over again, multiple times. The other, I think, a fascinating area of research is to really figure out the minimal residual disease, particularly in the setting of a curative early stage setting, like stage 1 to 3 lung cancers of any kind. And there have been studies done in many cancers, including lung cancer, where persistent cell-free DNA after definitive chemoradiation in stage 3 potent for prognosis. So can you imagine how useful that information will be if this is confirmed? And the question then is, what do we do with the high-risk population? So you can design studies focusing on that population, so you don't have to take the entire population and do longer and more expensive studies. And then as we have more and more therapies in advanced disease setting, early recognition of progression may be important. I'm not sure if they're there at this point now in many cancers, but I think this may become very important as we have more therapies in advanced disease. Lack of response by an early surrogate marker, drop in cell-free DNA, might be an indicator that they have to be enrolled on other studies or other therapies. So I think this is going to be a big area of clinical practice and research in the coming years.
That's great. Dr. Marshall, any comments from you?
Yeah, I think especially from the prostate cancer standpoint, I totally agree that I think that we're kind of there. I think in clinical practice, like, testing is probably underutilized rather than like overutilized. And I think that will expand sort of, especially like repeat testing for patients. And in the example of some of the diseases I talked about too, there can sometimes be a long lag time between when you get tissue from like a radical prostatectomy, for example, and then like the development of metastatic disease, which is sometimes hard to biopsy. So these other modalities are going to be important too. And then I think what we're starting to learn in some of the clinical trials and the way that we're even real world information is the sequencing of therapies as we get more therapies that are working for people, and finding optimal sequencing of therapies, combination of therapies, standard therapies in combination with targeted therapies, and then also looking at new targets, because we know that even though I like lump together all HRR genes, that the response of those tumors to PARP inhibitors, for example, is not all the same across those mutations.
That's great. Maybe you can just briefly comment also on in your disease, I mean, prostate cancer, germline testing as well as somatic tissue and/or liquid biopsy testing. How do you, the usage of these different tests for practitioners in metastatic or advanced prostate cancer, or even early stage, if you can comment on where do you see it now? Where do you see it going?
Yeah, so like I mentioned earlier, like germline testing has a broader indication in prostate cancer than even somatic testing does. And then one of probably the main challenge I would say with somatic testing that we have in prostate cancer is like the age of tissue, and then the difficulty in repeat biopsying of metastatic sites that are either lymph nodes that might not be accessible, but certainly like bone metastases, which are common in prostate cancer and hard to biopsy. So in those scenarios, I think liquid based biopsies are increasingly important to be able to get some of the somatic tumor information. And then, germline testing we've seen, and we know now that prostate cancer is one of the most heritable cancers. So it's certainly important, even going back to screening and how we, think about who should be screened and how for prostate cancer.
Great, thank you. And Ezra, I'll throw the question to you, and maybe you can just even comment more broadly about the future of precision oncology. Obviously, now that you've joined Tempus and you see what we're working on.
Yeah, clearly it's something I believe in. I'm honestly, I'm not sure I have much to add to the discussion so far. I think we're clearly here. We're now trying to figure out. We're in the era of how do we use this information, what information we need to get for all patients. I think the challenges ahead of us are obviously how to apply precision oncology to immunotherapy. The biomarkers there, I would say, are okay, but I think many of us would agree that we could certainly use better predictive biomarkers in the immunotherapy space, especially as we're going to see more and more combinations emerge. We certainly, the era of liquid biopsy is here, and we talked about how we're going to utilize those tools going forward. I really do believe that they will be early indicators for us of all the things that we talked about, early disease progression, surveillance in minimal residual disease, and eventually it'll influence our interventions, and I think, to extend patients' lives. And then, of course, this whole the whole field of germline alterations and the implications there. So there's so much to think about, and I think the key is, as again we alluded to in this webinar, really collecting the data and doing those large scale analyses to help us determine how to match the best therapy to the best patient at the best time.
Excellent, thank you. Well, in the final few minutes, I'll just make sure I include a reference to our current portfolio of tests. There has been a recent change, and that is that that we've always performed the whole transcriptome RNA sequencing. That has now been separated out into a separate test called XR. So XT refers to the 648 gene solid tumor DNA sequencing panel, with the option for a tumor normal match sequencing, as we discussed earlier, available for solid tumor and hematologic malignancies, which also include the immune biomarkers that you see here. The XR is actually now a separate assay that is on the order form of a separate checkbox, if you will. And this actually gives options for those who may already have their own DNA-only sequencing services where only RNA is needed, and allows that to be ordered separately. And this, of course, facilitates an improvement in ability to detect validated fusions, as well as altered splice alterations. The XE is the whole exome DNA sequencing, often for research use. The XF, I think, is unchanged in the sense that this is a 105 gene ctDNA panel of 105 genes, providing all of the level 1 evidence, actionable gene alterations that one would rely on in the instance when XT may not succeed. One can use this as an auto-conversion option using the same tube of blood from the incidental tumor normal match sequencing. Also, as well, one can perform the XF sequencing in conjunction with the XT, should that be in the physician's judgment to be useful. And so this really provides a flexibility of options. It can be done auto-conversion, it can be done in conjunction, or it can be done standalone separately. This test will also expand to 523 genes. We have offered this on a kind of a limited basis commercially, and this includes the blood-based TMB assessment in blood. So this will be scaled up and produced later in several months for a more general offering. And then the XG panels, there are two, a 52 gene and 88 gene panel for the more common genetic alterations and for a more comprehensive assessment. This does come with familial counseling services if ordered. And so down at the bottom, you can see that there are add-on additional tests that can be ordered. The pharmacogenomic test, DPYD, and UGT1A1 are pharmacogenomic tests that can be useful in the instance when one is considering 5-FU-based therapies with DPYD and or irinotecan or sacituzumab therapies for UGT1A1, as these may imply potential needs for dose alterations. The other RNA-based algorithms, HRD, homologous recombination deficiency, is an RNA-based algorithm, with the exception of in breast cancer and in ovarian cancer. This is DNA-based, based on loss of heterozygosity. And the tumor of origin is a useful algorithm for those cancer of unknown primary patients. Again, an RNA-based algorithm that predicts the likely tumor of origin based upon the data that has been researched in our database. And the purest algorithm is a relatively new algorithm in prostate and pancreatic cancer to differentiate between the classical and the basal subtypes of that disease based on RNA expressions, potentially helpful for considerations on a prognostic basis when considering first-line chemotherapy options. And then finally, the IHC test that you see here. So with that, I think we are at our program end, and I do want to thank our faculty and especially Dr. Govindan, Dr. Marshall. Thank you very much for both being investigators with us, presenting the data at ASCO, and also joining us to present the data and discuss it here. I think this is really, as you all said, the beginning of many learnings for us. And I think we appreciate the collaboration in research and in education that you've joined us for. And Ezra, thank you very much for your comments and your insights. Having you in the company now is, I think, a great benefit for Tempus. And with that, I'd like to conclude and thank everyone for joining us. And please, if you feel you need to, if you would like to refer to these slides, we will make them available. Thank you very much.
Thanks, everybody. Thanks
so much, everyone. Bye.